Jeremy Willian, and I'm a student physical therapist assistant with Jeff State. Today I'm here to present a TKA. My patient is a 59-year-old female, Miss Miller. Again, the patient is a 59-year-old female, 4-day status post right knee replacement. Patient's history is unremarkable, and doctors have given orders of weight bearing as tolerated. During the initial evaluation of the patient, a couple of subjective and objective things to note is the patient complains of symptoms with weight bearing less than 5 minutes, with sit to stand and sitting with knee flexion. She states that her primary goals are to return to gardening and to ascend and descend her stairs independently. The right patella has decreased mobility in all directions compared to the left, and there's poor VMO contraction noted with right quadriceps isometrics. During the reevaluation 2 weeks later, or 2 weeks 4 days status post, patient complains of symptoms with walking more than 10 minutes or 1,000 feet, with reciprocal stair climbing and in-range knee flexion. It should be noted that the walking has more than doubled since the initial evaluation 2 weeks prior. In addition, she states that she has been doing household ambulation without her cane the last 3 days. Patient ambulates independently on level surfaces 1,000 feet with cane, and the right patella and tibia glides have improved since the initial evaluation. However, there's still limited compared to the left lower extremity. The patient's right patella has decreased mobility in all directions compared to the left. For this reason, I think it is important to utilize joint mobilization to the patella or patellar glides, which will reduce patellofemoral adhesions and increase right knee flexion and extension. Grade 3 and Grade 4 patellar glides in the caudal encephalod and medial lateral directions will be utilized to increase active right knee flexion and extension by 20 degrees to allow for easier ambulation, which is the goal at this particular point in time. Next is a video demonstrating this particular technique or joint mobilization. Please enjoy. We are doing joint mobilization to the patella. It will assist the patient in knee flexion and knee extension. This should help to minimize the scarring associated with the TKA, and this will be done by moving the patella inferiorly and superiorly through the webbing of my hand. We'll move in superiorly and hold for 3 seconds, and then inferiorly, holding for 3 seconds. We'll do this approximately 10 times before moving to medial and lateral patellar shifts or glides. And how we'll do this is, instead of using our spacing, our web spacing in our hands, we'll just use our fingertips. We will simply shift the patella medially and laterally, being sure not to depress the patella in any way. So you really don't want to pick up on it, but you definitely don't want to push down on it either. Again, we'll do this approximately 10 times. In addition, we will instruct the patient how to do this at home themselves and ask them to do it throughout the day. Right knee is warm and shows edema compared to the left knee. For this reason, I think it's important to include elevation, ice, and compression at home with leg fully extended as a patient education. The elevation, ice, and compression will reduce inflammation and edema, and maintaining a fully extended knee with the leg elevated will increase knee extension range of motion. The picture below is a representation of a flexion contracture. This occurs typically with this patient population because when they go home and they elevate their leg by throwing a couple pillows underneath their ankle, and they put a bag of ice over the wrap across their knee, they typically like to get comfortable and put a pillow underneath their knee, and it reduces the stress being placed on the knee and therefore reduces the pain. The patient is doing this just because they don't know of the importance of that knee extension and the role it plays during gait. I think it is probably the most important thing to stress not to put that pillow underneath their knee and to make sure that that leg stays elevated and straight. So I have a video coming up next that portrays how I think this particular situation can be and should be handled, perhaps. Mr. Miller, hi. What is this?
I want to talk to you about that.
You know better than this. You're not supposed to have the pillow underneath the knee. It gives you flexion. We want you to be an extension, okay?
I'm sorry.
You're going to get a flexion contraction. You're going to be here a lot longer than you want to. Trust me, you don't want that. Let's lift this leg up.
Certainly.
Up, 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 up.
Oh.
Down, down. And let's get this underneath there. You can't lift it that high. That's good, though. You've got to have this ice on there. You've got to have it elevated. And we don't want any flexion contractures, okay?
Okay.
That's how we want it. That's how you do it at home, okay?
Okay.
Alright. See you in a little bit.
Alright.
I mentioned in the beginning of this presentation in the objective portion of the initial evaluation, poor VMO contraction was noted with right quadricep isometrics. For this reason, I believe a home exercise program consistent of quadricep setting or quad sets is appropriate. This will promote quadricep strengthening and knee extension. It should be noted that quadriceps are one of the most affected muscle groups due to the surgery, and it is extremely important to strengthen them to gain that knee extension that we've spoken of. So one of the goals for this patient is to increase active right knee extension by 20 degrees to allow for easier ambulation. This exercise is performed by having the patient sit or lie on their back with their involved legs straight and uninvolved bent. The uninvolved is bent as to not stress the lower back of the patient. That's why that's important. What you will have them do is press the back of their knee downward towards the mat or ground. This will tighten the muscle on top of their leg, the quadricep, and move the kneecap towards them. Have them hold this position for 3 seconds and then relax. Should be performed 15 times, 2 to 3 times per day, or excuse me, 15 reps, 2 to 3 times a day. It is important to ask the patient or remind the patient with every exercise to stop if there is pain and to always breathe. Diagnosis and rehabilitation potential for this patient is good. As you probably noticed in the initial reevaluation comparison, the patient made great strides with ambulation and stair climbing and a couple of other things. Their ambulation increased from having symptoms less than 5 minutes to doubling that without symptoms. In the reevaluation 2 weeks post initial evaluation, the patient was ambulating 1,000 feet with their cane. Cane use is indicated as patient progresses from partial to full weight bearing. Ambulation without an assistive device, particularly during outdoor walking, is not advisable until the patient has attained full or near full active knee extension and adequate strength of the quadriceps and hip musculature to control the operating lower extremity. Patient progressed to moderate protection phase approximately 5 to 8 weeks post initial evaluation and should return to functioning without symptoms approximately 9 to 16 weeks post initial evaluation. This patient should return to the previous level of function. However, it should be noted that these timelines for returning to function and making it to the moderate protection phase are vague or not precise, of course. They're just kind of estimated timelines. The patient's compliance to the home exercise program and sticking to the patient education given by the PT or PTA will ultimately play a major factor in the entire rehabilitation process, the outcome, and of course the timeline. However, going back to this patient, they made great strides in 2 weeks and it's believed that they will return to the previous level of function. So again, thank you for your time, and I hope you enjoyed my presentation. Have a good day. Bye-bye.